Hi, good morning, everyone. And I'm Fong Yiting from Taiwan. And today's topic is about the uterine leiomyomas and endometriosis. Uterine leiomyomas, which are also known as myomas, fibroid or fibromyomas, are well-proliferated, well-circumscribed, pseudo-encapsulated benign tumor composed of small muscle and fibrous connective tissue. Myomas are the most common uterine mass and the most common neoplasm found in the female pelvis, and they are present in 20% to 40% of women of 35 years of age or older, and rarely can be present in adolescents. They vary in diameter from 1 millimeter to more than 20 centimeter. Myomas are benign neoplasms that arise from uterine smooth muscle. These smooth muscle tumors may be found in organs outside the uterus, including the fallopian tube, vagina, round ligament, uterosacral ligament, vulva, and GI tract. Cytogenetic studies suggest that myoma arise from a single neoplastic smooth muscle cell. In other words, they are monoclonal tumors resulting from somatic mutation. Uterine myomas are estrogen and progesterone sensitive tumors. Consequently, they develop during the reproductive years. After menopause, myoma generally shrink and new tumor development is infrequent. These tumors are classified based on their location and direction of growth. The International Federation of Gynecology and Obstetrics defines myoma as 4 types. The first type is submucosal myoma, and the FIGO type is 0, 1, and 2. The second type is intramural myomas, and the number is 3, 4, and 5. And the third type is subserosal myoma, and the number is type 6 and 7. The fourth type is the other, which located at the cervical or parasitic myoma, and the number is number 8. Submucosal myomas are located beneath the endometrium and can grow into the uterine cavity. And type 0, which the mass is located entirely within the uterine cavity. And this is the type 0. And type 1, if less than 50%, is located within the myometrium. And this one is the type 1. And type 2, if greater than 50% of the mass is surrounded by myometrium. And this one is the type 2. The intramural myomas are the most common variety, occurring within the myometrium of the uterus as isolated encapsulated nodules of varying size. As these tumors grow, they can destroy the uterine cavity or the external surface of the uterus. Subserosal myoma are located just beneath the serosal surface and grow out toward the peritoneal cavity, causing distortion of the peritoneal surface of the uterus. When these are attached only by a stalk to their progenitor myometrium, they are called pedunculate myoma. The other type of myoma, like cervical myoma, is located in the cervix rather than the uterine corpus. Myomas are pseudo-encapsulated solid tumors, well demarcated from the surrounding myometrium. The pseudocapsule is not a true capsule and results from compression of fibrous and muscular tissue on the surface of the tumor. Because the vasculature is located on the peripheral, the central part of the tumor is susceptible to degenerative change and necrosis. The tumors are smooth, solid, and usually pinkish white. depending on the degree of vascularity. The surface typically has a trabeculate, fleshy, wall-like appearance. Myomas are composed of groups and bundles of small muscle fibers in a twist wall fashion. Microscopically, these appear as small muscle cells in longitudinal or cross-section intermixed with fibrous connective tissue. Vascular structures are few, and mitosis are rare. The picture shows myoma are composed of plain, spindle smooth muscle cells characteristic by elongated, blunt ended nuclei and tapered eosinophilic cytoplasm. The cells are arranged in interlacing fascicles that intersect at right angles. Myomas are usually well circumscribed, and the interface between the myoma and adjacent myometrium can be seen grossly and microscopically. These tumors are usually more cellular than the surrounding myometrium. A variety of degenerative change may occur in myomas that alter the growth and microscopic appearance of the tumors. Degenerative change occurs secondary to alteration in circulation, either arterial or venous, postmenopausal atrophy, or infection, or they may result from malignant transformation. Hyaline degeneration, the most common type of degeneration, is present in almost all myomas. It is caused by overgrowth of the fibrous elements, which lead to a hyalinization of the fibrous tissue and eventually calcification. Cystic degeneration may occasionally be a sequel of necrosis, but cystic cavities are usually a result of mesomatous change and liquefaction after hyaline degeneration. Necrosis is commonly caused by impairment of the blood supply or severe infection. A specific kind of necrosis is the red or carnose degeneration, which occurs most frequently in pregnancy. The lesion has a dull reddish hue and is believed to cause by aseptic degeneration associated with local hemolysis. Mucoid degeneration may occur when the arterial input is impaired, particularly in large tumors. Areas of hyalinization may convert to a mucoid or mesomatous type of degeneration. The lesion has a soft, gelatinous consistency. Further degeneration can lead to liquefaction and cystic degeneration. Infection of a myoma most commonly occur with a peduncular submucosal myoma that first become necrotic and then become infected. Calcification of myoma is a common finding in postmenopausal patients. The symptoms vary greatly depending on size, number, and location of the myoma or myomas. Most women with myoma are asymptomatic. Symptoms occur in 10% to 40% of patients. Abnormal uterine bleeding is the most common symptom associated with uterine myomas, occurring in as many as 30% of symptomatic women. The typical bleeding pattern is menorrhagia, or excessive bleeding at the time of mens. Normally, the mens is more than 80 milliliter. The increase in flow usually occurs gradually, but the bleeding may result in a profound anemia. Possible factors include necrosis of the surface endometrium overlying the submucosal myoma, a disturbance in the hemostatic contraction of normal muscle bundles when excessive intramural myomatous growth occurs, an increase in surface area of the endometrial cavity, or an alteration in endometrial microvasculature. Uncomplicated uterine myoma usually do not produce pain. Acute pain associated with fibroids is usually caused by either torsion of a pedunculate myoma or infarction progressing to cavernous degeneration within a myoma. Pain is often crampy with a submucosal myoma within the endometrial cavity, and severe cramping can occur as the uterine contraction to try to deliver the fibroid through the cervical os. As myomas enlarge, they may cause a feeling of pelvic heaviness or produce pressure symptoms on surrounding structures. Urinary frequency is a common symptom when a growing myoma exerts pressure on the bladder. Urinary retention, a rare occurrence, can result when myomatous growth create a fixed retroverted uterus that push the cervix anteriorly under the symphysis pubis in the areas of the posterior uretrovesicular angle. The unilateral ureteral obstruction can be caused by lateral extension or intraligamentous myoma. A markedly enlarged uterus that extends above the pelvic brim may cause ureteral compression, hydroureter, and hydronephrosis. Constipation and difficult defecation can be caused by large posterior myomas. Compression of pelvic vasculature by a markedly enlarged uterus may cause varicosis or edema of the lower extremities. Compression of pelvic vessels can lead to the development of deep venous thrombosis within the pelvis and pulmonary embolus. Infertility may result when myoma interfere with normal tubal transport or implantation of the fertilized ovum. Large intramural myomas located in the corneal regions may virtually close the interstitial portion of the tube and predispose to ectopic pregnancy. Submucosal myoma may impede implantation if larger than 4 to 5 cm. The endometrium overlying the myoma may be out of phase with the normal endometrium and thus provide a poor surface for implantation. Increased incidence of abortion and premature labor occur in patients with submucosal myoma. Less successful results with in vitro fertilization occur in patients who have submucosal fibroid when compared to controls. Uterine myomas found in 0.3% to 7 to 2% of pregnancies are usually present before conception and may increase in size significantly during gestation. Red degeneration is occasionally observed in late pregnancy. This condition is due to central hemorrhagic infarction, and the key symptom is pain. It may also be associated with nausea, vomiting, rebound tenderness, mild fever, and leukocytosis. Preterm labor may be increased in women with myoma. The risk of preterm labor increases with the size of the myoma. In the third trimester, myoma may be a factor in malpresentation, mechanical obstruction, or uterine dystocia. Large myoma in the lower uterine segment may prevent descent of the presenting part. Intramural myoma may interfere with effectual uterine contraction and normal labor. C-section may be necessary for delivery, and postpartum hemorrhage is more common with uterine myoma. The diagnosis of uterine myoma can be made with confidence in 95% of cases based on physical examination alone. During abdominal examination, uterine myoma may be palpated as irregular nodular tumor protruding against the anterior abdominal wall. Myomas are usually firm on palpation. Softness or tenderness suggests the presence of edema, malignant, or degenerative change. During pelvic examination, the most common finding is uterine enlargement. The shape of the uterus is usually asymmetric and irregular in the outline. The uterus is usually freely movable unless concomitant pelvic disease exists, such as endometriosis or pelvic adhesions. In the case of submucosal myoma, the uterine enlargement is usually symmetric. Some subserosal myoma may be distinct from the main body of the uterus and may move freely, which can be confused with anexa or extrapelvic tumors. The diagnosis of cervical myoma or pedunculate submucosal myoma may be made on examination if the tumor extends through the cervical canal and into the vagina. Occasionally, a submucosal myoma may be visible at the introitus, and the picture shows this round hyperemic myoma and its elongated stalk have prolapsed from the uterine cavity through the cervix and into the vagina. Additional diagnostic studies are based on individual presentation and physical examination. Hemoglobin and hematocrit are obtained in case of excessive vaginal bleeding to assess the degree of anemia and adequacy of replacement. Coagulation profile and bleeding time are recommended when the history is suggestive of a bleeding diathesis. Transvaginal sonography or three-dimensional sonography may be used to assess uterine dimension, myoma location, interval growth, and anexa anatomy. The sonography appearance of myomas vary from hypo to hyperemic depending on the ratio of small muscle to connective tissue and whether there is degeneration. The picture shows the transvaginal sonography of the intramural myoma, and the second picture is the 3D transvaginal sonography of a submucosal myoma. Saline infusion sonography can identify the presence of pedunculate submucosal myomas and endometrial polyps. And the picture shows the submucosal fibroid is clearly outlined during saline infusion sonography. And this is the submucosal fibroid. Hysteroscopy or hysterosalpingography may be used to evaluate the endometrial cavity in the evaluation of patients with uterine myoma and infertility or recurrent pregnancy loss. The first picture is the type 0 submucosal myoma that we've seen through the hysteroscopy. And the second picture is the type 1 submucosal myoma. And the third picture is the type 2 submucosal myoma. MRI has been found to be more effective than ultrasound in demarcating individual myomas, which may affect treatments and also in assessing risk of malignancy. MRI is also better at discerning other causes of pathology, including adenomyosis and aneurysms. The treatment for myomas must be individualized and may be non-surgical or surgical. Treatment decision is based on symptoms, fertility status, uterine size, and rate of uterine growth. In the absence of pain, abnormal bleeding, pressure, or large myoma, observation with periodic examination is appropriate. And this is especially true if the patient is nearing menopause, which time the myoma will atrophy as estrogen level fall. During the expectant management, bimanual examination should be performed every 3 to 6 months to determine uterine size and the rate of tumor growth. After slow growth or stable uterine size has been confirmed, annual follow-up may then be appropriate. Rapid growth, that means a change of 6 pregnancy weeks in size or more than 12 months or less of observation, is suspicious for malignancy and surgical intervention is indicated. Endometrial biopsy may be indicated in patients with abnormal bleeding. Regular blood counts are warranted. Iron deficiency anemia is common with menorrhagia, and iron replacement may be required. For the medical treatment, non-steroidal anti-inflammatory drugs, NSAIDs that inhibit prostaglandin synthesis and administered on a schedule rather than as needed basis can be used to reduce menstrual blood flow. NSAIDs also treat pelvic discomfort or pressure. Low-dose oral contraceptive or progestin treatment have been used to induce endometrial atrophy and to decrease prostaglandin production in women with myomas, and this may also reduce blood loss. The levonorgestrel releasing intrauterine system, marketed as Mirena, in small studies improved myoma-related heavy menstrual bleeding. Importantly, tumors that destroy the endometrium cavity preclude Mirena use. Also, compared with women without myoma, those with submucosal myoma experience higher device expulsion rate. Long-acting GnRH agonists suppress gonadotrophin secretion and create a hypoestrogenic state similar to that observed after menopause. They are administered in the form of a subcutaneous implant or an intramuscular depot injection, and they can administer as a monthly or every 3 months injection. Although individual response varies widely, a median reduction in uterine volume of 50% has been observed with GnRH agonists. Maximum response is seen after 12 weeks of treatment, with no added advance to 24 weeks of treatment. Decreased size is secondary to a decrease in blood flow and cell size. Cell death and a decrease in cell number are not observed. Myomas rapid regrow, returning to baseline size within 12 weeks after GnRH treatment is discontinued. Use of GnRH agonist treatment is not recommended for longer than 24 weeks because of the long-term effect of a hypoestrogenic state, most notably osteoporosis. Therefore, agonist treatment is often used prior to surgery to achieve a small-sized fibroid or uterus, which may impact the procedure chosen. For example, hysterectomy or myomectomy may be performed through a smaller laparotomy incision or by vaginal or minimally invasive surgery approach. Long-term use of GnRH agonists with add-back hormone replacement treatment is another alternative and can be used if the patient is a pro-surgical candidate. And this is the medical treatment for the myoma. The first one, NSAID, may improve the symptoms of dysmenorrhea, and the oral pill and the progestin treatment and the Mirena can improve the symptoms of dysmenorrhea and menorrhagia. And for the GnRH agonists, they can improve the symptoms of dysmenorrhea, menorrhagia, pelvic pressure, and infertility. For the surgery, surgical intervention is indicated when symptoms fail to respond to conservative management. Just like the patient has excessive bleeding that interfere with normal lifestyle or lead to anemia and chronic pelvic pain or pressure. Or maybe the patient had protrusion of a pedunculate submucosal myoma through the cervix, or rapid growth in a leiomyomatous uterus at any age. This finding warrants exploration because it may represent a leiomyosarcoma as opposed to a benign myoma. Because this malignancy occurs primarily in women older than 40 years of age and their incidence increase with advancing age, Any increase in uterine size in a postmenopausal woman warrants surgical exploration. Other reasons for surgical intervention including repetitive pregnancy loss caused by myoma after other etiologies has been excluded, or progressive hydronephrosis demonstrated by ultrasound or intravenous pyelography, or impaired renal function. The type of surgery to be performed depends on the age of the patient, the nature of the symptoms, the size and the location of the tumor, and the patient desire about future fertility. Myomectomy involves the removal of single or multiple myoma while preserving the uterus. Myomectomy is a reasonable approach in symptomatic women unresponsive to conservative treatment who desire future fertility or uterine conservation. Hysterectomic myomectomy can be used in patients with submucosal myoma and often lead to an improvement in menorrhagia. A hysteroscope is inserted transcervically into the uterine cavity and the myoma is resected without having to enter the abdominal cavity. Criteria for hysteroscopic resection include submucosal fibroid, FIGO type 0, 1, and type 2, which less than or equal to 3 cm, of which at least 30% produce into the endometrial cavity. Abdominal myomectomy is performed through an incision in the abdomen with gentle dissection of the fibroid out of the uterus, followed by carefully uterine reconstruction. The incision can be performed through midline vertical or phalansteal incision. The indication for laparoscopic myomectomy or robotic-assisted laparoscopic myomectomy are the same as for abdominal myomectomy. Minimal invasive surgery may be associated with shorter recovery time, shorter hospital stay, adhesion formation, and postoperative pain compared with laparotomy. And this is the picture of robotic-assisted surgery. And this is the picture of laparoscopic surgery. With the help of video camera, video monitor, only 4 small incisions was made during laparoscopic surgery. Myolysis describes myoma puncture with tools to permit mono or bipolar cautery, laser vaporization, or cryotherapy. Laparoscopic myolysis that using laser or coagulation current, and cryomyolysis that using a negative 180 degrees Celsius probe of myomas have resulted in a persistent decrease in size of myoma and appear to be another promising treatment option. And the picture is the SSR system for myolysis. Hysterectomy is the definitive treatment for uterine myomas if the indication for surgery are present and if childbearing is complete and uterine observation is not important to the individual. With hysterectomy, both the myoma and any associated disease are removed permanently, and there is no risk of recurrence. Hysterectomy can be performed vaginally, abdominally, or laparoscopically, depending on patient and uterine factors. MRI-guided high-intensity focused ultrasound is a relatively new treatment option that uses ultrasound-generated heat to cause cell death. The fibroids are localized, and heat from a phase array transducer is able to converge on a focal area and produce protein denaturation. An early study have shown an improvement in symptoms in nearly 60% of patients. Uterine artery embolization. Over the past 15 years, this procedure has emerged as alternative to traditional surgery. UAE is performed by inserting a catheter into the femoral artery to access the uterine arteries. Small particles such as gel foam microsphere or polyvinyl alcohol particles are injected into the uterine arteries, causing occlusion of the blood supply to the uterus and myomas, thus causing shrinkage or necrosis and death of the myoma. Given its rich collateral blood supply, the uterus will not necrose even if both arteries are occluded. It results in a 60% reduction in size of myoma and control menorrhagia in more than 90% of cases. Typical candidates are women with symptomatic myoma who are approaching menopause, no longer desire fertility, have a large uterus, have multiple health risks for surgery, or do not desire surgery, and have uncontrollable menorrhagia. Okay, here finish the first topic about the myoma. Any question? If there's no other question, let us see some video during the hysteroscopy exam. Okay, this is the first video that I record during the hysteroscope exam. And this is the type 0 myoma we can see during the hysteroscopy exam. And this is the endocervical canal, and there's endocervical polyp at here. After passing the endocervical canal, we can reach the isthmus level at here. And because the patient had C-section before, so there is an CS scar defect at the anterior lower segment of the uterus. And this is the type 0 myoma that we can see through the hysteroscope exam. This is the right corners, the left corners, and the base of the type 0 myoma at the anterior cavity. And the posterior cavity is okay. This is the base. And this is the scar defect and endocervical polyp. The second video is about the type 1 submucosal myoma. After enter the endocervical canal, we reach the isthmus level and enter the uterine cavity. We can see one type 1 submucosal myoma at the posterior cavity. And this is the type 1 submucosal myoma and small endometrium polyp. This is the left corners and one small endometrial polyp at left side. Type 1 submucosal myoma at posterior. And the third video is about the submucosal myoma type 2. This is the endocervical polyp. After enter, we reach the isthmus level and one type 2 submucosal myoma at the anterior cavity of the, you can see the type 2 myoma at here. And this is the fundus of the uterus, right corners and left corners, and one small endometrial polyp. And this one, type 2 myoma, is located at the anterior cavity. Okay, this is the hysteroscopic exam that we can found type 0, type 1, and type 2 submucosal myoma. Okay, let's have 10-minute break. And after 10 minutes, we will come back and start the second topic about the endometriosis. Hi everyone. Anyone have question about the first topic? No? Okay. If you've got any question, you can ask me after we finish the second topic. And the second topic is about the endometriosis. Endometriosis is the presence of functioning endometrial glands and stroma outside their usual location within the uterine cavity. Significant pelvic adhesions with or without associated inflammatory cells or hemocysteine-laden macrophage often result. Endometriosis is primarily a pelvic disease with implants in or adhesions of the ovaries, fallopian tubes, uterosacral ligaments, rectal sigmoid bladder, and appendix. Less commonly, endometriosis can be found outside the pelvis, suggesting a metastatic spread. This generally benign disease usually affects women in their reproductive years. The estimated incidence of endometriosis is 10% to 15%. Data suggests that 30 to 40% of patients with infertility may have endometriosis. The cause of the endometriosis. The first one is retrograde menstrual flow. This theory, initially postulated by Dr. John Sampson in the early 20th century, postulated that the retrograde flow of menstrual debris through the fallopian tubes caused the endometrial cells to spread into the pelvis, form implant there, and serve as irritative foci, which stimulate coilomic metaplasia and differentiation of the peritoneal cells into endometrial type tissue. The second cause of endometriosis is hematogenous or lymphatic spread. Endometriosis at sites distant from the pelvis may be caused by vascular or lymphatic transport of endometrial fragments. This could explain the presence of endometriosis at distant sites, such as the brain and lungs. Another theory concerns coilomic metaplasia and suggests that the parietal peritoneum is pluripotent and can undergo metaplastic transformation to tissue histologically identical to normal endometrium. The transformation of coilomic epithelium results from some yet unspecific stimuli, but it can occur early in puberty after a few menstrual cycles. The next is genetic influence. The relative risk of endometriosis is 7% in siblings, compared with 1% in control groups. The increased incidence in first-degree relatives suggests a polygenic multifactorial pattern. An immune factor, which retrograde menstruation, refracts menstrual tissue in the most women, is usually cleared by macrophage, natural killer cells, and lymphocytes. For this reason, immune system dysfunction is one likely mechanism for endometriosis establishment. This may explain why, although many, if not all, women experience retrograde menstruation, not all women develop endometriosis. There are multiple mechanisms to explain the pain observed with endometriosis. The first one, infiltrating endometriosis may cause irritation or direct invasion of pelvic floor nerves. And the second one is the active bleeding from endometriotic implants may directly irritate peritoneal nerves or indirectly cause symptoms by accumulation of blood products. Pain may result from growth factors, cytokines, prostaglandins, and histamines in endometriotic tissue and peritoneal rate of women with endometriosis. Moderate to severe endometriosis is thought to cause infertility by causing adhesions and scarring of the ovaries and fallopian tubes. Whether minimal endometriosis causes infertility is still under investigation. Patients with endometriosis may have increased concentration of macrophage in the ampullary portion of the fallopian tubes. Macrophage chemotactically attract to areas where endometriosis is present, may interfere with ovulation and corpus luteum formation, and with fertilization through gamete phagocytosis. Factors produced by macrophage may interfere with sperm motility. The prostaglandin F2 alpha increases the tone and amplitude of the cervical and uterine musculature and narrows the cervical os. It may increase the venous contraction of the uterus and the intensity of uterine contractions, therefore increasing the degree of dysmenorrhea. Prostaglandin also may interfere with placentation or implantation. Interleukins are also secreted by activate macrophage. Exposed embryos are less likely to progress to the egg cell stage at 24 hours. Tumor necrosis factor and other cytokines may stimulate endometrial cell proliferation. The signs and the symptoms of the endometriosis include the secondary dysmenorrhea, and is the most common symptom of endometriosis. Typically, the pattern with endometriosis is that of increased severe menstrual pain over time. Pain with ovulation is associated with endometriosis. Unilateral pain can suggest endometriomas within the ovary. Pelvic pain for more than 6 months is considered chronic. However, many women with endometriosis are asymptomatic, and the degree of endometriosis often does not correlate with the existing amount of pain. Dyspareunia is the meaning of painful intercourse and may be caused by endometrial implant of the uterosacral ligaments or the endometriomas of the ovaries, or maybe fixed retroversion of uterus and or fixed location of ovaries in the cul-de-sac due to endometriosis and adhesion. The endometriosis may cause the infertility, and endometriosis has been demonstrated by laparoscopy as many as 30 to 40% of women who are infertile. The associated symptoms include urinary symptoms. Urinary symptoms are common in patients with endometriosis. As many as 1/3 of patients with endometriosis have urinary tract involvement. The highest frequency of such involvement occurs in the bladder, followed in frequency by the lower ureter, upper ureter, and kidney. Symptoms range from intermittent dysuria, frequency, and urgency to complete ureteral obstruction. Gross or microscopic hematuria is present in many patients and frequently follows the menstrual cycle. Bladder involvement can mimic symptoms of interstitial cystitis and need to be differentiated. The GI symptom. 7 to 35% of all women with endometriosis have bowel involvement. Symptoms may vary from dyschezia, that means pain on defecation, and hematogygia, bloody bowel movement, in this case associated with menstruation, to other symptoms of partial or complete bowel obstruction. And the symptom can be abdominal bloating, intestinal cramps, nausea, and vomiting. And the thorax is a rare but significant site of endometriosis. The foci of endometriosis can cause cyclic monthly pneumothorax, and we can call it catamenial pneumothorax. Hemolysis, that is cough up blood, or hemothorax. The onset of chest pain usually occurs within 2 days of mens. The endometriosis has been documented to occur in other distant sites, including nasal passage, and the patient will have monthly nosebleed, the brain, catamenial seizures, and the umbilicus. Endometriosis can also occur in surgical incision, typically laparotomy from C-section or surgery for endometriosis, and in laparoscopic port sites. For this reason, it is important to not remove endometriotic tissue directly through the skin incisions. This is the picture of endometriosis within a phalansteal incision scar. And this one is the CT image, show a subcutaneous mass extending down to the anterior abdominal wall fascia on the left. This is the excised mass, and bisect mass show white fibrous scarring within yellow subcutaneous fat. The diagnosis of the endometriosis. The first one is the history. The patient might have one or more of the characteristic symptoms that we described just now. A history of endometriosis in the patient's mother or sister is also important. Markers for endometriosis is CA125, and CA125 is elevated in endometriosis. It is a test for cell surface antigen found on coilomic epithelium, which includes the endometrium. This test is useful as a marker for response to treatment or recurrence. CA125 is not a diagnostic test for endometriosis because it lacks specificity. It can also be elevated in ovarian cancer, PID, and inflammatory bowel disease. During pelvic examination, we can find irregularity and tenderness of uterosacral ligament. Is the character finding on vaginal and/or rectovaginal examination. The endometriomas are palpated as nasal mass, often fixed to the lateral pelvic wall or to the posterior coolie sac. The uterus is often in a fixed retrograde position. The pelvic imaging is necessary in a woman with pelvic pain in whom endometriosis is suspect in order to look for ovarian endometriomas. Pelvic ultrasound is the best screening tool for visualizing the ovaries and uterus. Sensitivity and specificity of vaginal ultrasound to diagnose endometriomas range from 64 to 90% and from 22 to 100%. An endometrioma classically is cystic with homogeneous low-level internal echoes, often described as ground glass echogenicity. This picture shows the transvaginal sonography demonstrating ovarian endometriomas. A cyst with diffuse internal low-level echoes is seen. MRI is better for clarifying the findings on ultrasound. On MRI, the endometriomas are typically hyperintense in T1 imaging and hypointense on T2 imaging. In adolescents with severe dysmenorrhea, pelvic ultrasound should be performed to look for obstructive Mullerian anomalies such as blind, non-communicating uterine horn or a hemi-obstructed vagina with a uterus didelphys. This picture is the MRI image of an endometrioma, just lateral to the rectum. Consistent with subacute blood, low-intensity signals are found on T2 weight sequence, and high-intensity signals are seen on T1 weight sequence. Although imaging can add clinical information, laparoscopy is the primary method used for diagnosing endometriosis. The endometriotic implants are variable color and can be red, white, and black. Endometriosis may cause deep tissue damage, resulting in local scarring and reduplication of peritoneum and leading to surface defect or Allen-Masters peritoneal defects. Physicians should strongly suspect the possibility of endometriosis in all patients with demonstrated pelvic peritoneal defects at laparoscopy. This picture is the endometriosis diagnosed during laparoscopy. Several red and clear endometriotic lesions seen on the pelvic peritoneum of the posterior cul-de-sac, and this one. And the second picture is the several brown-black lesions on the ovarian surface. The classification of endometriosis. The extent of formation of classic lesions, ovarian involvement, and adhesive disease is classified by the American Society of Reproductive Medicine. Classically, severity of endometriosis is graded by stage 1 through 4, corresponding to minimal, mild, moderate, and severe disease respectively. And for the stage 1, the total amount that we add up is 1 to 5 points, and for stage 2 is 5 to 15 points, and for stage 3 is 16 to 40 points. And if the number that add up more than 40 points is stage 4. For the treatment, expectant treatment may be appropriate in young women who have mild pelvic pain with apparent endometriosis on laparoscopic and no immediate interest in pregnancy. Goals are relief of the dysmenorrhea and prevention of further growth of endometriosis. NSAID, the prostaglandin synthetase inhibitors are effective in controlling endometriosis-related dysmenorrhea. Atopic endometrium responds to cyclic hormone secretion in a fashion similar to normal endometrium. It has been well documented that pregnancy tends to alleviate the symptoms of endometriosis. It was this observation that led to the initiation of hormone suppression of men as the basis of medical treatment for endometriosis. The combined oral contraceptive pill. This is usually the first-line treatment for endometriosis and can be administered in the traditional cyclic fashion, allowing menstruation, or administered continuously to prevent menstruation. Continuously administered estrogen-progestin combined oral pill create a pseudopregnancy state associated with amenorrhea. The pseudopregnancy causes residualization, necrobiosis, and resorption of the atopic endometrium. This treatment is appropriate to control pain associated with menstruation and ovulation with endometriosis. Progestin can be given alone for treatment of endometriosis by suppressing ovulation and therefore induce amenorrhea. They cause an ovulation by enhancing the negative feedback of estrogen at the hypothalamus, leading to a hypogonadotrophic hypoestrogenic state. Progestin also have an antimitotic effect on endometrial tissue, the eutropic endometrium, as well as in the endometrial implants. This results in eventual atrophy of endometrial implants. The progestin may be administered through several routes. The first one is oral form. Norethindrone acetate 5 mg daily and Dianogus 2 mg daily. The second form is injection. Dipepomedroxyprogesterone acetate can be given every 12 to 14 weeks. The third form is intrauterine. That is levonorgestrel releasing intrauterine device, marketed as Mirena. GnRH agonist. GnRH is a decapeptide that controls the release of the anterior pituitary hormones, FSH and LH. GnRH has a very short half-life. It is rapidly destroyed by entopeptidase in the hypothalamus and pituitary gland. Chemical alteration of the amino acids at position 6 and 10 produce synthetic derivative of GnRH that resist cleavage by endopeptidase that retain a high affinity for the pituitary GnRH receptor. The effect is downregulation and desensitization of the pituitary, which result in lack of ovarian estrogen production. Androgens are now used as second-line agents for endometriosis due to their androgenic side effect. Danazol is a synthetic 7-alpha ethinyl testosterone derivative. Its predominant action suppresses the mid-cycle LH surge to promote chronic anovulation. Danazol occupies receptor sites on sex hormone-binding globulin and thereby increase serum-free testosterone levels. It also binds directly to androgen and progesterone receptors. As a result, danazol creates a hypoestrogenic, hyperandrogenic state that induces endometrial atrophy in endometriotic implants. Another type of androgen is gastrinone. Gastrinone has anti-progestational, anti-estrogenic, and androgenic effects. Gastrinone equals the effectiveness of danazol and of GnRH agonists for relief of endometriosis-related pain. The aromatase enzyme converts androgen precursors such as androstenedione and testosterone to estrone and estradiol. Aromatase inhibitors such as letrozole and anastrozole will inhibit the production of estrogen within the endometriotic lesion. For the surgical treatment, medical treatment does not treat adhesion or eliminate endometriomas. Surgery is the treatment of choice in cases that present with considerable anatomic factors. Example, adhesions, endometriomas, ureteral obstruction. The success of surgery in relieving infertility is directly related to the severity of the endometriosis. And conservative surgery involves the excision, figuration, or laser vaporization of endometriotic lesions, the excision of ovarian endometriomas, and the resection of severely involved viscera, leaving the uterus and at least one ovary and fallopian tube intact. This can usually be accomplished by laparoscopy, but in severe cases, laparotomy may be required. For some women, transection of presacral nerves lying within the presacral space may provide relief of chronic pelvic pain. And the picture shows the presacral space. Hysterectomy. This procedure is definitive and most effective treatment for women with endometriosis who do not wish to retain fertility. This is appropriate for women with intractable pain or multiple previous conservative treatment or surgery. Radical surgery involves a total hysterectomy and bilateral submucosal. This approach is used in patients who do not desire future fertility or in those whose endometriosis is so severe that it precludes any attempt at reconstruction. Estrogen replacement treatment is important in patients who undergo radical surgery to prevent osteoporosis and treat hypoestrogenic symptoms such as hot flush, night sweats, sleepiness, and vaginal dryness. Okay, here is my reference for today's topic about the endometriosis and the uterine myoma. And thanks for your attention. Any question from you guys? Okay, if you don't have any question, maybe we can see some video that I download from a page website. Okay, this is the video about the hysteroscopic myomectomy that I download from the page website. And let's forward. This is a female, 44 years old, and she has symptoms of dysmenorrhea and menorrhagia with anemia for months. And she was diagnosed as myoma uterine for years without regular follow-up. She got poor menstruation and was suffered from dysmenorrhea and iron deficiency anemia for months. She denied any abdominal pain or abdominal fullness, no constipation or bowel habit change, or dizziness or dyspnea. For her past history, there was no known drug or food allergy, no chronic illness, and she had given birth to 3 children and C-section 3 times. His last menstruation period is this one, and she have used oral pill for her contraception. During the pelvic examination, there was slightly enlarged uterus, and the lab findings show anemia. For the ultrasound findings, this is the uterus in transverse view, and this is the mass in uterine cavity, size 3.7 times 2.6 centimeter. During the hysteroscopic findings, okay, is a submucosal myoma type 0 from right uterine corpus. And this one is the submucosal myoma. And let's forward to the procedure. Okay. During the hysteroscopic surgery, we will gently introduce an advanced hysteroscope into the uterine cavity under visual. And we will examine the uterine cavity anatomy and pathology. And you can see this is the type 0 myoma. We will shaft the protruding portion to the level of the endometrium. We use the U-loop to shaft the myoma piece by piece. And the loop usually placed behind and always advance it toward the surgeon. During the myomectomy, the myoma chips should be extracted for better visualization. And later on, we use the shred cutting loop to dissect the base of the myoma. And last, if there's bleeding, we can use the rolling ball to do the coagulation. And the procedure is done. And the second video is about the laparoscopic myomectomy, and that can also download from the Apache website. Okay. And let's forward. Okay, this is a 45 years old female and came due to abdominal fullness, regular hypomenoric menstrual cycle. And there's a palpable non-tender mass over the hypogastric area. During the ultrasound finding, we can found one fundal nodule, 7.7 times 7.3 centimeters myoma. And this is the transvaginal ultrasound. And the longitudinal view of the uterus is show the uterine is 12.7 centimeter in length. And there is a fundal nodule, 7.7 times 7.3 centimeter. And the diagnosis is myoma of the uterus, and we plan to do the laparoscopic myomectomy. And first, we insert the port cephalic and lateral to the uterus. And we lysis of the adhesion first to insert the port. And this is the uterus. And we dilute the vasopressin and inject into the serosal and myometrium overlying the myoma. And this is the location of the myoma. Okay, we do the incision first using the monopolar and use the ultrasonic energy to extend. And this is the myoma. We can use the suction device as a brown probe to show out the myoma from its capture. And this is the myoma. And after myoma is removed, we will suture the wound using the 1-0 monocryl. And last, the fibrin sealant agent is applied over the uterine defect. So after the myomectomy, the wound was sutured, and you can see the uterus have returned to normal size. And this is the left fallopian tube, left ovary, and right fallopian tube. Okay. And this is the laparoscopic myomectomy video. Okay. Do you guys have any question about the video or the topic that I just talked about? Any question? question. Mhm. Okay, if no question, let me ask you some question. Let me share this first. Okay. This one. The first question. What type of myoma is shown in this sonography image? This one. A. Intramural. B. Subserosal. C. Submucosal type 0. Or D. Submucosal type 1. Which is the answer for this question? Okay, yes, the answer is A, intramural type, because most of the myoma is located inside the myometrium. Okay. And okay. Second question. Myomas account for 2 to 3% of fertility cases. Which of the following describe the mechanism by which myomas may disrupt fertility? A. Occlusion of tubal ostia. B. Distortion of normal uterine contraction. C. Disruption of implantation secondary to distortion of the endometrial cavity. D. All of the above. So what is the answer? Okay, the answer is D, all of the above. And the third question. 148 years old patient presents with complaints of worsening menorrhagia. She has no other medical problems. Three-dimensional sonography evaluation reveals the finding as shown this one. Or accept which of the following is a suitable choice for medical treatment in this patient. Accept which one? A. Oral pill. B. Departmental progesterone acetate. C. GnRH agonist. D. Levonorgestrel releasing intrauterine system. Which one can be used for this patient? Accept which answer? The answer is D. The levonorgestrel releasing intrauterine device is not suitable for this patient because this patient suffer from submucosal myoma and they will destroy the endometrial cavity, and sometimes after the Mirena is insert, because the cavity is not smooth, it will cause the device to expose from the uterus. And the fourth question. Sonographically, endometriomas are typically described as which of the following? The A, solid with intracystic blood flow. C, cystic with hyperemic internal echoes. C, solid with diffuse internal low-level echoes. D, cystic with diffuse internal low-level echoes. Which is the answer? Yes, the answer is D, cystic with diffuse internal low echo. The fifth question. Okay. Medical treatment for endometriosis may include or accept which of the following? A, progestin. B, oral contraceptive. C, aromatase inhibitor. D, androgen receptor blocker. And what is the answer for this one question? The fifth question. Yes, the answer is D. It's not the androgen receptor blocker, it's the androgen, like the gastrinone and danazol. We can use to treat endometriosis, but it's the second line agent for endometriosis due to the androgenic side effect. Okay, any question? Okay, if there is no any question, thanks for you guys today, and hope we can see sometimes after this one. And that's all for today. Thank you very much. Goodbye.
Thank you, Dr. Huang.
Yes.
Thank you very much.
Yeah. Thank you all, guys.